Okay, so the next speaker is Jack Sobel, and Jack's going to talk on something we a lot of times talk about: invasive fungal infections, but some of the local infections are some of the toughest ones that we deal with. And Jack has a career. He is the guru. He is the main man to actually deal with vulvovaginal candidiasis. We thought it was good for him to come up and talk about this, his experience, as there are more and more of these new drugs available or coming. They're being studied in this patient population. So it's a great opportunity to introduce him, to give us what's the role for the new antifungal agents in vulvovaginal candidiasis. So Jack.
Thank you. Thank you, John. I'd like to thank the scientific committee and organizers for inviting me to this delightful place, the best part of which is to renew acquaintances with so many old friends. Didn't realize how much I missed them. So, a tale of two new antimycotics for vulvovaginal candidiasis. Well, VVC is very rarely given the opportunity to be presented at these meetings. It's not life-threatening. There's no mortality involved. And therefore, it's not really never been the major interest of most of the pharmaceutical companies. But I can think of no other anatomical site with the opportunity to study an antifungal drug with a yeast, common yeast, to study the virulence factors of the yeast, to study the interaction of the yeast and the microbiota, the microbiome, including the innate and adaptive immune system, the inflammasome's response, as well as the host in general, both the diabetes or estrogen influence, all within one anatomical site. It's an extraordinary opportunity to study these interactions. I haven't got a slide on disclosures, but I wanted to start off by telling you I've been on the scientific advisory board, big board, of both Synexis and Mycovia for almost 10 years. I've had a very intimate and strong positive interaction with both those companies and the teams. I have the various members of those teams are on speed dial with me. I call them weekly. And I can't think of any better model at a time where academics are being criticized for their interactions with pharmaceutical companies of a more positive outcome than is represented by my relationship with these pharmaceutical companies over a decade. I know both these drugs well from the in vitro lab studies for activity, pharmacokinetic studies, the animal model studies, the phase 1, the phase 2, the phase 3 studies. And what today will be an introduction to these drugs, because we still do not know how to optimally use these drugs. Fluconazole was introduced in the early 1990s because of HIV, AIDS, esophageal and oral candidiasis, where it was a remarkable breakthrough. But in essence, fluconazole became initially approved in the late 90s for vulvovaginal candidiasis, and has dominated treatment of vulvovaginal candidiasis for almost 3 decades. So the one thing we learned about dealing with fluconazole is, regardless of the dose that was approved by the FDA to be used in Candida vaginitis, it took another 10 years of working with this drug to learn how to optimally use the drug. This is going to happen as well with both ibrexafungerp and as well as oteseconazole. We are just starting to learn how to use these two drugs, and we can't do a direct comparison today. So, the burden of vulvovaginal candidiasis is extraordinary, enormous, worldwide, all strata of society, millions of office visits annually. Just remember that recurrent Candida vaginitis is thought to occur in between 5 to 8% of healthy adult women during their reproductive years. Not a day goes by that I don't get a phone call from a practitioner asking me how to treat this patient who's got Candida vaginitis with this species or this strain or this organism. And part of the problem is not simply selecting the appropriate antifungal, But the problem really lies with the practitioner, and most practitioners do not understand the disease. This is not candidemia, where you eradicate the organism of the bloodstream and then you turn to the source, you aim at sterilizing, removing candida at the source. This is a chronic colonization process. You never cure a genetically determined entity. We're not going to talk about the genetics today, although that might have made an even better presentation today. But you can only control the situation. And that's what practitioners don't understand. How can I control as opposed to cure? Just remember, though we talk about approval for VVC, we have to establish, are we talking about acute Candida vaginitis? Is it sporadic? Is it mild? Is it severe? Are we talking about recurrent diseases? Is this a chronic form? And this is not usually apparent when one deals with the approval notices from the FDA. Most importantly, asymptomatic candidiasis is hyperendemic worldwide. And yet we still do not fully understand the mechanism by which you can get abundance of yeast in the vagina and yet no symptoms. What determines the absence of symptoms? And this is much more a function, once more genetically determined, of the innate immune system, the inflammasome response of those non-white cell dependent inflammatory response, the inflammasome and the epithelial cells, and the cytokine response, because normally the vagina tolerates Candida without symptoms developing. And that's the goal of therapy, not sterilization of the vagina. So, just a couple of words about pathophysiology, because as is evident from our last comments, about what we can hope to accomplish by treatment. We talked about endpoints in the last few talks. So following colonization, which is dependent on the interaction between Candida and the TLR and other receptor sites in the epithelial cells, a sort of truce or normal tolerance exists whereby the immune system tolerates the presence in Candida in low numbers without these yeast expressing the virulence in factors and without any invasion occurring. This is normal, and this is what we hope to occur. When the organisms increase in number in large numbers and they start to invade the walls, we used to teach, we used to say that Candida vaginitis is not an infection of the vaginal walls, the mucosa, it's an infection of the vaginal secretions. That's nonsense. This is a truly superficial invasive infection, and we didn't recognize this because we'd never biopsied these patients. But we have an inflammatory response that occurs when there are increased numbers, the yeast start to express the virulence factors, and they invade the vaginal walls per se. Not all Candida species have the same capacity to invade. The non-albicans Candida species, more resistant to the azole drugs, have a reduced virulence capacity and much more likely to colonize, and should not be driving treatment indications, which is a problem in its own right. So I just wanted to put the slide up just to emphasize the critical role of a genetic disorder dependent on multiple polymorphisms, which influence both the vulnerability of the patient to become colonized in the first place, and as well as the immune response threshold to response. So depending on these two factors, as well as the protective interaction with the microbiota, you're either going to remain asymptomatic or develop symptomatic disease. Symptoms are a result of the inflammatory response, not the organism directly. This is, for example, you'll read a lot lately about biofilm produced by Candida. Well, Candida doesn't produce a biofilm in the vagina. There's not a single paper of note that's ever shown that there's a microbiome, that there's a biofilm in the vagina. There is for bacterial vaginosis, as you see in this fluorescent antibody study on the right. That's a true biofilm. On the left-hand side, you see the normal vaginal mucosa after biopsy. And you can see the Gardnerella and the various bacteria that invade the biofilm and are present in the biofilm, and they are critical to the recurrent nature of that infection. But there's no biofilm in Candida, in the vagina. Instead, what you see in this beautiful biopsy specimens from Swietzinski in Berlin, or the extent to which there is superficial invasion invariably in the presence of symptomatic infection. And if you're going to talk about recurrent disease, this is the source of the recurrence together with the inflammatory response at a different threshold for reaction. I'm not going to talk about diagnosis. So let's talk about fluconazole. Fluconazole has dominated in all studies. More than 80% of women receiving treatment for Candida vaginitis receive fluconazole. I have prescribed more fluconazole than anyone in this planet. As an epitaph on my stone will be written, "Here lies a man who dearly loved fluconazole." You can't believe the numbers of women worldwide that have benefited from the availability of a drug that was made to get into the vagina, that is well tolerated, safe. You know, when we talk about new drugs, we emphasize all the problems and inadequacies of fluconazole, but they are few. This is an inexpensive drug. It wasn't inexpensive to start. The first 5 years, it was a struggle to get it. And so the two new antifungals are struggling now with expense issues. That will pass. 5, 10 years, guys. It'll pass. They'll become generic. But at the moment, unfortunately, after being it was initially prescribed as a single-dose therapy, most use of fluconazole today is off-label. 90% is off-label. 2 drugs, 3 drugs, when you give it, how long you give it for. That isn't yet happening with these 2 new drugs that I'm going to talk about eventually. So why do we need help with fluconazole? This drug is contraindicated in pregnancy. Nothing is more difficult than managing chronic and recurrent Candida vaginitis in a pregnant woman. We clearly had hoped both these 2 drugs earlier on, several years prior to the FDA approval being granted, that would be available for use in pregnancy. No, tough. And in recurrent Candida vaginitis, as I'm going to show you, you can control the infection well with fluconazole and these new drugs, but you don't cure the patients. As soon as you stop this, with cessation of the drug, you get a recurrence because you haven't cured the genes. Fluconazole, unfortunately, but we have about 10% of the population today that are intolerant, side effects, allergic, and most importantly, increase in numbers of both species with intrinsic resistance as well as acquired resistance, C. albicans, Clobrata, Krusei. These are the 3 most difficult drugs, species that we have trouble with fluconazole today. So this was the opening for new drugs. So I just wanted to show you, this is an old slide to show you that for recurrent Candida vaginitis, if you look at the red line, this is fluconazole. While fluconazole is given on a weekly basis at a low dose, the reason why the drug is so well tolerated, it is always given at a low dose. This is not cryptococcal disease. You never give less than 400 milligrams for cryptococcal disease. This is 150, usually 100. So while you take the fluconazole, your ability to control symptoms is greater than 90%, close to 95%. But it's when you stop. As you can see at the end of 6 months, you see the fluconazole has a recurrence rate of up to 60% in the next 6 months. And within a couple of years, it's virtually 80, 90% compared to placebo. So the limitations of fluconazole, to summarize, the lack of protective immunity, recolonization is inevitable, the genetic basis as well as we control, we do not cure. So our brixyfungib, who were introduced to last night, you already know about this new class of drugs, antifungals, broad spectrum, having activity against many taxons, genera, and active against most of the echinocandin as well as the azole-resistant strains. Oral, single dose, 2 doses in 1 day therapy, and well tolerated with extensive tissue distribution and a recent approval with Brexafemme for Candida vaginitis. This is just the list of the species where you compare to fluconazole. You see the enhanced activity of this drug as a glucan synthetase inhibitor, 1,3-B glucose desynthesase inhibitor. Activity is terrific against including Candida auris. So the very first study that was done was the so-called Dove study, and I always go back to this study because its importance was it was actually compared to fluconazole. One of the problems with the FDA, and I hope the FDA members are listening in if they're not present, is that new drugs are not required to be compared to drugs that are widely available and currently used. What a mistake. Every practitioner, when presented with a new drug, wants to know, can I use this drug when patients are failing with fluconazole? But you're not required to show any superiority or comparative data compared to fluconazole. So the companies don't do that. In fact, they're discouraged from doing that. So you can see on the left-hand side that the activity of ibrexafungerp against compared to fluconazole is almost identical. There's no question you can, with a single dose, one-day therapy with ibrexafungerp, and the same thing is going to apply to oteseconazole, are comparable to those of fluconazole. Are they better for the average 90% of the patients who... Not when you look at a week or 10 days, which is the first endpoint. If you go further and you go to 25 to 30 days, you start to see differences. And you can see you get a more sustained effect here with ibrexafungerp compared to fluconazole. But the numbers of patients, were 27 patients in the study. This has not yet been exploited and not been interpreted into what benefit it does in terms of subsequent recurrent attacks. But it's not required by the FDA. Following that study came the VANISH studies, the phase 3 studies, the very large studies, and once more the ibrexafungerp was compared to placebo and was statistically significant. Okay. What about recurrent Candida vaginitis? Well, all three professional societies, ACOG, IDSA, CDC, recommend an approach of using an induction regimen followed by a maintenance regimen. The purpose of the induction regimen is to reduce the fungal load, the abundance of fungi, before you put them onto the maintenance. So the first study was the CANDLE study, the only study done by Synexis. And in this study, they used fluconazole, 3 doses, to induce remission, and then used a monthly as opposed to weekly study with fluconazole. And it was statistically superior to placebo. Would it be better than fluconazole? It has the advantage of being taken once a month and for a shorter period, perhaps not 6 months, maybe 3 or 4 months. But we have no follow-up data because the FDA didn't require to show what was the recurrence rate when you stopped the ibrexafungerp. So these are still studies to be done. And this is just to show you the comparison versus placebo, clearly significantly superior. Superior to fluconazole, we don't know. So in all these studies. So let's talk about oteseconazole to complete the study. Oteseconazole was designed to inhibit, it was a designed product to inhibit the fungal CYP51, and you're going to hear more details about how it works at lunchtime from Steve Brand. But this drug is, because of its design and its affinity to inhibit human versus, as opposed to the fungal CYP51, the enzymes, is such the potential for drug interaction is dramatically diminished, side effects are dramatically diminished, and the potency versus the various fungal things is greatly enhanced. What is really relevant, this drug has a half-life of approximately 138 days. There's no precedent. You can measure the drug after 138 days. So, is it active? It's highly active against a wide variety of species of Candida, all the species. Its activity against glabrata is particularly striking. And its use for recurrent Candida vaginitis was in its first and most important study. This study has recently been published in the New England Journal of Medicine Evidence. And in this study, they used an induction dose of fluconazole with a maintenance regimen of oteseconazole for 11 weeks, a total of 12 weeks of therapy. And their ability to prevent recurrence while taking the drug, the maintenance, as well as after stopping the drug, in other words, 6 months afterwards. This was a study that extended for a year. This they got right. Comparing it to fluconazole, they did not. But the recurrence rate was dramatically diminished, as in this thing. No question. They were struggling to find isolates that were in from women who recurred, and they were not resistant to fluconazole. And this drug, as with Abrixafungal, well tolerated per se. They followed up the study with using an induction regimen, not of fluconazole, but of Abrixafungal, with oteseconazole on 2 days, 600 milligrams day one for induction, with 450 the next, followed by weekly for 11 weeks. And once more, there was a dramatic decrease in recurrence rates, both during and following cessation. You'll also hear at lunchtime how this therapeutic control effect continues for at least for up to 2 years, if not longer. Both these two new drugs are contraindicated in pregnancy. Moreover, the FDA has determined that oteseconazole or Vulvovaginal cannot be used in women of reproductive age. Another blow, because it effectively decreased 70% of the potential patients I had lined up for use of this drug. So, a real problem. In summary, my last slide. 2 new antifungals for potential use in both acute, recurrent, and chronic vaginal candidiasis. Although the indications are similar, they are very different in their pharmacokinetics, a lot more different in their activity against especially some of the resistant strains, very different in terms of their pharmacokinetics. Both, like fluconazole, contraindicated in pregnancy. We are still learning how to use both these drugs, and I'd love to be here in 5 years, John, to invite me back to tell you how really we're going to be appreciating these 2 new agents. Both, however, are going to compete with fluconazole. How can anything beat fluconazole? Remember my epitaph. Both, however, are more expensive, and this will be the driving force for their use in the next couple of years. But they clearly are of value in select populations. These select populations, to start off, are going to be small, but will grow as we get a better understanding about how to use these 2 new drugs. And with that, I'll end. I know I'm over my time. Thank you for your attention.